How did the Eliminate Yellow Fever epidemic strategy become one of the strongest global partnerships in immunization?
I is more than an immunization partnership. I is also a mindset.
I'm Marie Braquemont from the World Health Organization's Department of Communications. In this episode, we'll review the EYE's progress as its 10-year period of operation nears its end. And we'll hear what still needs to be achieved from Dr Laurence Cibrelus, global lead for the EYE strategy.
We want to turn yellow fever into something commonly talked about, into something routine, into something systematically addressed.
And we'll also hear from Dr Ephrem Lemango, Associate Director and Chief of Immunization at UNICEF.
Over 350 million people protected for life against yellow fever since 2017. That is a very huge number. That's a wonderful success.
We are Eliminate Yellow Fever Epidemics, EYE for short, with the inside story on yellow fever's expanding global risk. This is EYE on Yellow Fever. Episode 18, a groundbreaking partnership. Dr Laurence Cibrelus, welcome to EYE on Yellow Fever.
Good afternoon, Marie. Thanks for having me on the podcast.
Dr. Cibrelus, as we are approaching the EYE's evaluation target in 2026, what is your assessment of the progress made so far?
Well, I would say it's remarkable on many levels, be it for the vision, the engagement, and the drive, or for the strategic and technical progresses and innovations. It's actually been a humbling project to lead, a fascinating one. There are several ways to measure success, but I think that one figure stands out. And since the inception of the EYE strategy in 2017, an estimated 365 million people have been protected against yellow fever for life in Africa. And of these people, 264 have been vaccinated via campaigns. It's quite remarkable. This means that we achieved in about 7 years twice as much as the Yellow Fever Initiative achieved in 8.
So how did the independent feedback at the midterm evaluation of the EYE feed into what has been achieved since, and what lessons did EYE learn from this?
Well, it's been a very important effort, and actually one that I recommend other programs to undertake. It might seem a little daunting, obviously, but it's very important to have independent external eye looking at your work. For the EYE strategy, it's been very helpful to identify the priorities area to advance, the adjustments needed in a changing and resource-constrained environment. And I think that's what defines now the acceleration phase of the EYE strategy. Namely, what is the essential change we need to see to reach our targets by 2026, and which ones might need refining. For instance, in that evaluation, there was emphasis on the resurgence of yellow fever outbreaks in countries which already benefited from large-scale preventive mass vaccination campaigns, but where some children's or some communities and populations have been missed by vaccination. And this is particularly challenging for the EYE strategy because the countries affected are the ones that benefited from the large-scale preventive campaigns under the yellow fever initiatives that lasted from 2006 through 2014 and are therefore different from the countries which were the initial focus or the initial priority of the EYE strategy, where those kind of large vaccination drives were yet to be either initiated or completed. And we're working toward developing strategies for these. In the midterm evaluation, there also was emphasis on urban risk and the associated risk of international spread, or on the importance of children routine immunizations to avoid further resurgence of yellow fever outbreaks.
Dr. Cibrelus, we've talked about threats that we have identified, and some of them you've already mentioned, such as urban risk, climate change, vaccine hesitancy. How are we mitigating with these risks?
So these risks, as you rightly said, were highlighted by the midterm evaluation. And what we've done is that we've since refocused some of our activities and accelerated some, particularly on urban readiness, with elements on risk communication, community engagement, more work with the civil society organizations or the non-governmental organizations and the humanitarian community, more work on the vector, i.e. the mosquito front of yellow fever. These are elements that we're doing in partnership with other groups, obviously, because this is really the vision for I, including for the vector part, which is in collaboration with the global arboviral strategy. We are also developing strategies to ensure that the mobile and vulnerable populations are identified and protected against yellow fever. You mentioned climate change, and interestingly, these communities are also particularly impacted by climate change and climate stress with the associated displacement, which in itself is or are risks for yellow fever outbreaks and importantly spread throughout the migration routes. And all these elements are being defined at the partnership level. And I want to emphasize that this partners consultation and engagement is really ingrained in our ways of working. And I do believe that's part of the ingredient of the success of the I strategy and partnership.
Could we talk a bit about preparedness, which is the ability to respond quickly to cope with an immediate crisis? So do you think we are better prepared as a result of the ICE work?
I do believe that we are better prepared to cope with outbreaks as a result of ICE work. There's still some way to go, obviously, and there continue to be challenges with outbreak response delays, for instance. But that really speaks to the dire realities of the countries with whom we work. And that's why our partnership is so important and needs to be grounded into the country's realities. And that's really what we're aiming to do. We are really trying to leverage and join forces with existing mechanisms that have complementary goals, if you like. One example of ongoing projects include the provision through the International Coordination Group on Vaccine Provision, the ICG, of longer-term support for countries such as Central African Republic, Cameroon, and Guinea, which are facing recurring yellow fever outbreaks. And the goal is really to build outbreaks preparedness and response capacity in an integrated fashion, meaning that whatever we will do or improve from the lens of yellow fever or to support advancing the yellow fever agenda will help addressing other epidemic-prone diseases. We are also developing pilots on urban readiness with a strong focus on the vector, i.e. the mosquito component of it, making sure that we know how many mosquitoes we have at a given time in a given area, and how we can engage the communities to reduce the density of these mosquitoes. And where they are not, we have reached levels of density and type of mosquitoes that are prone to sustaining and amplifying yellow fever virus transmission. But I would say and insist on the fact that the implementation of these activities, be they surveillance or control of the densities of these mosquito population, is extremely challenging. So we're piloting this in Cameroon, but we're also, to build knowledge and develop norms and standards, we're also updating the tool or the guide for vector surveillance and control. We're also training trainers, and with the goal to then train and empower communities to limit the number of what we call breeding sites for mosquitoes. And that's really important in urban setting, albeit, as I said, very, very challenging to implement due to lack of capacity and specific guidance. And I think this vision that we have is really also critical to I, meaning testing on a small scale, demonstrating value, and then develop strategies accordingly and scale them up. And then integrate them into broader mechanisms or projects to make it easier for the country in a way.
So we can be better at preventing outbreaks from happening in the future. The ICE work has led to forging strong partnerships. How do you think this has impacted on wider diseases initiatives other than yellow fever?
Some of the key strengths of I are around the leadership and coordination, but also the clear governance structure. One example I'd like to give is the work that we're doing on the annual vaccine allocation for large-scale preventive mass vaccination campaigns. We, first of all, rank the yellow fever high-risk countries at national level in terms of epidemic and endemic risk, and we define those ranks annually. We'll build on this and then add layers of countries' absorptive capacities, whether they already have a funding mechanism in place, whether they need support, how committed the government is, etc. And so through the high risk analysis working group, which is the first layer, then through the high secretariat and the regional offices of both WHO and UNICEF, and then through the high program management group, which is the main nucleus driving the implementation of the high strategy, we define not only priorities, but also numbers of doses that we want and can allocate to the countries on an annual basis. So we are very transparent and standardized in the way we measure risk and we make decisions, and then the way we communicate about this. And it's been very helpful for the countries, but also for the yellow fever vaccine manufacturers and all the colleagues and partners involved in the procurement of vaccines. It's really optimizing vaccine allocation and vaccine impact. And I know this effort is really unique and has been cited as an example that other partnerships would benefit from.
The consequences of the COVID-19 pandemic continue to be felt today, including for vaccine-preventable diseases. How did the pandemic skew the I strategy plan? And what did we learn from the pandemic that has moved us forwards?
COVID obviously had consequences on our work, especially on the component around children, systematic or routine vaccination. But COVID for the I partnership also saw one of the greatest moments of the partnership and what can be achieved when partners put in a joint, concerted and dedicated efforts. It has been quite wonderful. Actually, in 2020, we were able to vaccinate almost twice as much people as we did in 2019. So in year one of the pandemic, we've been able to almost double the number of people we protected for life against yellow fever via campaigns, making sure we will deliver those vaccinations to the people in need, to the people at risk for yellow fever outbreaks despite the pandemic, because we knew the yellow fever threat will not go away. It's been a remarkable joint and concerted effort. I want also to flag that one strategic objective, the second one on preventing international spread, did suffer during the pandemic, as we had to obviously reassess our priorities. But we are now recuperating, and that's part of the work we're doing on urban readiness, for instance.
What is still needed? What will be the next step to achieve everything in the EI strategy, not only by the EI strategy partners, but also the governments, the public health officials, especially in at-risk areas?
Concretely, at the moment, we've developed a 3-year action plan to guide the partnership across the levels toward the acceleration of the EI strategy. It's really important that we have a sustained, further increased country and regional participation. And this is really the key. We need countries and regions leading the charge. That's critical. And this is true actually also at the level of the global partners. There are exciting milestones that are coming up. And I want to flag that Ethiopia has committed to introduce the yellow fever vaccine into their national routine immunization schedule, and also to complete national preventive mass vaccination campaigns. We are also developing strategies for targeted vaccination campaigns to tackle the resurgence of the yellow fever outbreaks in the countries we have history of preventive mass vaccination campaigns. This is likely to take a few years, so we might need to add a few years to I as well. But we are working hard to get there, and these are very important times.
And we all know that one of the success of DI's strategy, as you rightly highlighted, is the number and the diversity of its partners. You've talked about I being a vision, a mindset, an objective to galvanize a busy community. Do you think the building of new and groundbreaking partnerships with very diverse organizations has led to a different scope for I beyond immunization in 2026?
And indeed, I is more than an immunization partnership. It's a multi-sectoral approach and hence a multi-sectoral partnership. But I think importantly, I is also a mindset. It's a very specific way of working. We're working at the global level, but also with a strong operational focus. at country and regional level. It's about, on the one hand, driving the global yellow fever community, providing thought leadership, developing norms and standards, ensuring that we have enough vaccines to meet the needs. It's also supporting innovations in diagnostics, and there have been tremendous progress in that areas. It's also about addressing questions on emerging risk, remaining adaptable and course-correcting as needed. But on the other hand, it's also very much about being concrete, being operational. We're very country-oriented. And we want the communities to engage more and more and ensure that we're responding to their needs. It's been a partnership with people that work with passion and dedication and joy almost. So I think that's a human adventure. That's how I would define the I partnership.
We've talked about climate change, urbanization. Can you give us some examples of these new risks that we have seen and that continue to emerge?
I think there's something critical that we had foreseen in the development of the I strategy and around the issues of the itinerant high-risk workers. And by high risk, we mean those with an exposed sylvatic exposures. These workers actually were one of the reasons for the creation of the I strategy, because they were linked to the spread of the 2016 dramatic Angola yellow fever outbreaks and the spread to Kinshasa in the Democratic Republic of the Congo. That made us realize that the risk of international spread was not so much linked to travelers, or was not only linked to travelers, but also to those high-risk workers who are exposed to the wildlife environment where the reservoir of yellow fever is, and then bring it into urban settings where there's potential for rapid amplification and dramatic amplification. And there's an interesting example that we've done in Central African Republic recently. It was around engaging with the private sector, and namely here with wood factories, to identify some of these high-risk workers that were suffering from yellow fever and with an actual outbreak, despite some of the local population in the area being protected against yellow fever, and they were not.
Dr. Cibrelus, how do you see the future for I, as we are coming soon to an end of the 2026 milestone, maybe not the end of the work on yellow fever, and what it means for you since you've been involved since day one in the strategy?
I see the future of I strong. Now I'm getting a bit emotional because you asked that personal question. It's been fantastic actually to see the evolution and the progress, the ups and downs really, but with a very positive and strong forward-leaning trend. It's been an accelerating and fascinating experience. I've enjoyed working with partners very much. I've enjoyed the work with the regions and the countries, seeing the change. I've appreciated being informed by them also, making sure we are addressing their needs to the best of our capacities. Yes, it gripped me day in and day out throughout these now 7 years. It's been a fantastic experience. I look forward to continue through the acceleration phase. I think there are many things that could be inspiring for others. And my main message for the yellow fever community and for others is always keep the needs of the countries in mind. We're working for them. We're working to support them. We're working in partnership with them. And that's very rewarding. Thank you.
My thanks to Dr. Laurence Cibrelus, Global Lead for the I Strategy. You are listening to I on Yellow Fever. This is episode 18, meaning there is now a wealth of previous episodes for you to go and find in your podcast player. If you're discovering us for the first time, please go ahead and give them a listen. We would also love you to spread word about the podcast. Please recommend us to friends or colleagues you think would be interested in learning more about yellow fever or have an interest in infectious diseases. UNICEF is one of the 3 primary partners in the I strategy, alongside the WHO and Gavi, the Vaccine Alliance, and many others. Dr Ephrem Lemango is Associate Director in charge of immunization at UNICEF. He sat down with my producer Amanda for this episode. Dr. Lemango oversees the overall global immunization efforts of UNICEF across different regions and countries. He is ideally placed to make an assessment of the progress made in reaching the ICE target vaccination coverage of 80%.
In my opinion, the effort to eliminate yellow fever epidemics, particularly in the African continent, is indeed making a commendable progress. And the main reason I'm saying this is because there are some promising signs where we are seeing progress in selected countries who are home to a significant number of populations.
As we heard from Dr. Cibrelus earlier in the podcast, there are also high-risk countries who have recently agreed to start implementing yellow fever campaigns within their routine immunization programs, notably Ethiopia.
Even challenged countries that may have difficulty of reaching 90% of children through routine immunization, do it very well in campaigns. And one very good notable example is recently Chad achieved about 91% of coverage with yellow fever campaign for an age group targeting between 9 months and 60 years. So all this positive progress made actually gives us the sense and the hope that we are able to achieve the 80% coverage that is needed to achieve herd immunity.
The consequences of the COVID-19 pandemic continue to be felt. In 2024, WHO and UNICEF published updated data on the number of children who have missed out on critical vaccinations against outbreak-prone diseases as part of their country's overall routine immunization schedules. Dr. Lemango explains how the vaccination coverage is still being affected by the pandemic and what still needs to be done to get back on track.
The data that we have analyzed over the years of the pandemic and a secondary effect of the COVID-19 pandemic has led to backsliding of immunization coverage across several countries. And the backsliding actually resulted in increasing number of fully unvaccinated children and increasing number of those who missed on all their vaccines, which we call them the zero-dose children. So we added up the number of children that were missed in 2019, which would have otherwise been caught in 2020, but unfortunately due to the pandemic, they weren't caught. So we added up with the ones in 2020, in 2021, in 2022. So the number in 2023 is actually 86 million children missed on one or more vaccines. And around 60 million of these are children who have missed in the entire set of vaccines, which we call them the zero-dose children. And as the number of unvaccinated children accumulated, we have also seen increasing number of outbreaks. The likes of measles outbreaks that are happening across countries, which are threatening the lives of children. And the number of measles cases have increased significantly. Countries with large and destructive measles outbreak have also increased. And it's not only measles immunity gap that we are seeing, even in those countries that have introduced yellow fever vaccination in their routine immunization, have also seen a decrease in coverage, and hence the need to really catch up with this. That is why last year, UNICEF, WHO, Gavi, and several other partners came together to announce an initiative called the Big Catch-up.
The Big Catch-up aims to reach the 80 million children missed during the pandemic, and to bring back up the level of coverage across those countries whose coverage has declined since the beginning of the pandemic. And finally, to strengthen the regular systems further to allow us to reach even those who had never been reached before the pandemic. It's a three-pronged initiative. Although early results are confirming that pre-pandemic recovery is progressing, and leading up to the hope that 23-24 is gonna be what Dr. Lemango has called the year of recovery, there are still problems to tackle.
The data we released in 2023 shows the overall coverage in 2022 has shown a significant recovery back to pre-pandemic levels. So it decreased from about 18 million zero-dose children in 2021 to about 14 million plus in 2022. But the challenge was this was driven by large, relatively well-to-do countries, the likes of India, Indonesia, a bit of Philippines, and Brazil, who have achieved significant recovery. And it does definitely mask the inequity across several countries. The overall African continent seemed to still continue to stagnate in coverage. And that does require a significant attention because a stagnating coverage in Africa would mean an increasing number of population that is still remaining unreached. And that is why we're saying 2022 has been a year of recovery driven by some large countries, while there are still remaining countries that will need to recover. The early data we are seeing in 2023 is showing us there is a continued recovery. The analysis has not been completed yet, so it's not official, but we hope it will continue.
So we are now closer to achieving routine immunization in some countries. But in Africa, where countries are at high risk for yellow fever, as well as many other outbreak-prone diseases, there is still much work to be done.
Despite the recovery of immunization, many of the countries we have as high risk in the African continent still have relatively suboptimal coverage in their routine immunization. So the number of zero-dose children still continues to increase due to the population increase. And when I say this, I'm generalizing because there are countries that are actually making considerable progress in this space. But there are countries challenged by conflict, countries like Sudan, countries like Ethiopia, who are facing man-made and natural catastrophes, and of course, civil unrest and war. So despite success in overall recovery, in catching up those children that were missed during the pandemic, we're not making progress in reaching zero-dose children. Before the pandemic, the estimate was about 12.9 million zero-dose children, at least in Gavi-supported countries. And we still have over 14 million children that are still zero-dose on a yearly basis. So the actual indicator that will make a difference in incidence of outbreaks or epidemics is the decreasing number of zero-dose children and the decreasing number of under-vaccinated children. That is an area which we are not really making progress and requires us to do much better in 2024 and 2025.
Given the challenge ahead, can it be possible to eliminate yellow fever epidemics in our lifetime?
I'm a very optimistic person. The main reason is, most importantly, yellow fever is not something that requires you to give the vaccine 2 times, 3 times, etc., to get a very good level of immunity. 2 is, despite the evolving challenge across countries, and despite the increasing number of conflicts, and of course associated mobility across borders, we also see countries being much more intentional, and they will make all the required efforts to be able to reach these communities that are trapped in some sort of fragility. But we are also, as partners, learning ways of doing business in those settings. So that is something to be hopeful for. In many places, for example, in Sudan, where there is conflict affecting even urban areas, as opposed to the usual remote areas, partners have found a way of setting up mechanisms to be able to provide health services even in camps of internally displaced people, and also really expanding services in functioning health facilities for people to be able to continue to use them in these conflict-affected settings. So that's the main reason I am optimistic that we're not just keeping quiet amid all this travesty. And if we add up all this together, we can safely assume that we'll be able to eliminate yellow fever epidemics in our lifetime.
Looking at the immediate future, what will be the next steps for the ICE strategy partners and for governments and public health officials in at-risk areas to accelerate everything to make sure that the ICE strategy has achieved as much as possible by 2026?
To be honest, this partnership is, I think, one of the most impactful partnerships given the number of people that it has been able to protect. Over 350 million people protected for life against yellow fever since 2017. That is a very huge number, a very big success. But keeping up with this and the aim of really eliminating yellow fever epidemics by 2026, which is basically 2.5 years from now, it is something that can be achieved, but it does take significant effort. It requires countries to continue to invest in strengthening their health and immunization systems, and to be willing to be able to introduce this vaccine both through campaigns and routine immunization, and the donors and partners that have been able to support this effort so far. But it goes without saying, it is the responsibility of the government to be able to provide all essential services, including vaccines and immunization.
The message Dr. Lemango really wants to drive home to governments is that investing in vaccines, investing in health, brings a significant economic return.
Yesterday, we just released a report, an analysis conducted by WHO as we start the World Immunization Week that talked much about the impacts of the expanded program on immunization over the past 50 years. This program has been so impactful to a level that it has saved over 150 million people in 50 years. And this shows you, and these are potentials realized, these are capabilities transformed into economic growth and broad productivity in countries. So it is important governments see the value of investing on vaccinations like yellow fever and many other vaccines, sees this as an economically sound investment. If we do all this together, it is possible to achieve what we are hoping to achieve in 2026.
The I strategy works to a disease-specific target, and there is also the Global Immunization Strategy, the Immunization Agenda 2030, which is agreed at the global level and focuses on decreasing mortality associated with vaccine-preventable diseases at a global level. So how does I fit into the Immunization Agenda of 2030?
The top line aim or goal of the Immunization Agenda 2030 is to decrease the number of zero-dose children by 2030 by half, which is basically the number of zero-dose children we had at the start of this decade. We need to go down to 6.6 million plus zero-dose children. Now we are quite higher than that, obviously. We are, in fact, higher than the pre-pandemic levels. So it does require an effort to accelerate our commitment and accelerate our initiatives to reach that target. And diseases such as yellow fever, measles, and so many other outbreak-prone diseases, the likes of meningitis, cholera, and all sorts of diseases, are the focuses. So the global effort to eliminate yellow fever epidemics is part and parcel of the Immunization Agenda 2030. It contributes to achieving the goals of the Immunization Agenda 2030 by decreasing the occurrence of outbreaks and epidemics, and in turn decreasing the number of people who die and suffer from such epidemic.
We've discussed the target of 2026 for the I strategy earlier in the podcast, as well as the next steps in the acceleration phase. But what is the vision of Dr. Ephrem Lemango for I after 2026?
Even though 2026 is the mark year that we hope to achieve our target, what we decide after 2026 depends on how much we have progressed in that target. And we have clearly seen the benefit of treating a particular disease with such laser focus and advocacy to be able to make a difference. So there is a value to keeping a particular focus on a disease to support the advocacy and communication and even the technical support on ground and the support to countries on a particular focus to a specific disease, which is basically system strengthening efforts. And in my opinion, yellow fever is something that is actually benefits from strengthening of the childhood immunization program, given that it is a vaccine that we give along with measles, which is an easy thing to do. So if we have strong systems that are able to deliver the vaccine in routine immunization, then post-2026, it can be a program that is given through routine vaccination program. It will need to be more focused post-2026, focused to selected high-risk countries, providing selected set of supports to governments, and leaving the rest to the overall Immunization Agenda 2030. It's important to keep in mind that this all depends on how successful we are by 2026. If we still remain with a significant number of countries to make progress, as in reference to our target of reaching 80% coverage, then it warrants us to keep the partnership as is, to learn from its successes and limitations, sharpen its focus on selected number of countries to continue to do what it has been doing well so far.
And on that, Dr. Lemango has one last thought he wants to share.
This is a very important moment because we are also celebrating the 50th year anniversary of immunization program as a global program called the Expanded Program on Immunization. And despite the successes, which really showed as a program that EPI has been able to save 1% every 10 seconds for the past 50 years. This is a miracle. And if you have a miracle of such capacity and potency, you would want to keep doing the same, if not better, to continue to make the impact that we have been making so far. And this would only thrive because in the future, we will have more vaccines. I am of opinion everything will have a vaccine. We have one for malaria now. And the future would also have therapeutic vaccines that are able to cure, including cancers, etc., any sorts of such autoimmune diseases also. So the future is a world of vaccines. So as we build programs in the future, including for yellow fever epidemic prevention, it is important to keep in mind we need to adequately invest in the systems and foundations that delivers these vaccines.
An inspiring glimpse of the future from Dr Ephrem Lemango from UNICEF. It's been a roller coaster ride so far for the ICE strategy, with many challenges overcome in the last 7 years, including the pandemic and the difficulties created by the speed of climate change and the outbreak of conflicts. And through it all, the ICE strategy has shown impressive results. These results are possible because of the power of the partnership. And it's a partnership that still has much work to do in the next 3 years and perhaps beyond into the future. I would like to thank my two guests, Dr Laurence Cibrelus and Dr Ephrem Lemango, for their in-depth overviews of the progress so far of the ICE strategy and its partners, as well as their clear vision of what still remains to be done. This episode of Eye on Yellow Fever was produced by Amanda Hargreaves with sound design by Adam Whaley. I'm Marie Bracmont. Eye on Yellow Fever is a Bengo Media production for Eliminate Yellow Fever Epidemics.